Hi everyone, in this video we're going to review the adult tachycardia with a pulse. Now tachycardia by definition is any ventricular rate over 100. However, I want you to kind of put a magic number in the back of your head, and that number is 150. So when looking at the ventricular rate, if it's less than 150, generally we're looking for a cause. Is the patient dehydrated? Are they in pain? Is there some cause for this tachycardia with the rate under 150? Generally. If the rate is above 150, greater than 150, now we're looking at the heart as the culprit. Not a cause, we're looking directly at the heart. Okay, next, the big question. Is your patient stable or unstable? And I want to make the distinction now between stable versus symptoms. In symptoms, they're subjective. It's whatever the patient's telling you. What are their symptoms? They may go, oh, I'm a little dizzy, I'm a little short of breath, my butt itches. Those are all symptoms. What we're looking for and we need to determine is your patient stable or unstable. And we're talking about that. We're specifically speaking about hemodynamic stability. Are they hemodynamically stable? Signs of being unstable: altered mental status, low blood pressure, crushing ischemic chest pain, signs of shock. That makes your patient unstable. Regardless of what symptoms they're telling you, are they hemodynamically stable or unstable? Now, if your patient has a tachycardia and they are hemodynamically unstable, immediate synchronized cardioversion. Synchronized cardioversion. You'll read in the literature where they suggest, if you can, give them a little sedative or something before you administer the cardioversion. However, if they're unstable, do not delay synchronized cardioversion to administer some sedative. Shock them. Now, for more details on how to perform synchronized cardioversion, just go and view our synchronized cardioversion video. Now, if your patient is stable, we got a little wiggle room. So at this point, we're going to look at the complex itself and determine, is this a narrow or a wide tachycardia? And the distinction is the width of the QRS, specifically 0.12 seconds. So looking at your ECG tracing, if the QRS is less than 0.12 seconds, we call that a narrow complex tachycardia. If it's greater than 0.12 seconds, that makes it a wide complex tachycardia, and that changes our approach to our drug administration. Now, if after looking at the QRS, we determine this is a narrow complex tachycardia, we have a stable patient, our treatment first is to try vagal maneuvers. Have the patient bear down. And I describe it like you're trying to have a bowel movement. Just bear down real hard. This stimulates the vagus nerve and hopefully will slow down the heart rate. Now, if that doesn't work, our first choice is adenosine for medication administration. 6 milligrams of adenosine, IV, rapid push, followed by a 10 or 20 ml syringe bolus of saline to help push that drug to the heart. Adenosine starts to wear off the instant it hits the blood vessel. So the object is to get a proximal IV, say 18-20 in the AC, push the adenosine in quickly, then follow that with a syringe bolus and push that drug to the heart as quickly as you can. Now, when administering adenosine, you want to warn the patient. Adenosine is a potent vasodilator, so their blood pressure drops and they feel, they don't feel good. So warn your patient before you give them the adenosine that this is a normal occurrence. We expect this to happen. On the monitor, you may see the characteristic asystole. It's typical, it's not permanent, it resolves, but you will see that on the monitor after you administer the adenosine. And hopefully the patient restores to a non-tachycardic normal complex rhythm. Now, if the first 6 milligram dose of adenosine is ineffective, you can repeat that with a 12 milligram dose. You're just going to double up and administer 12 milligrams rapid IV push. Now, if it turns out that the adenosine didn't work, you administered 6 milligrams, didn't work, 12 milligrams, didn't work. There are some other options. We can administer calcium channel blockers or beta blockers, but at this point, you really want to get an expert consult on the patient. Now, if after looking at your ECG, you determine this is a wide complex tachycardia, a QRS greater in width than 0.12, and the patient's stable, our treatment's going to be amiodarone. You're going to administer 150 milligrams infusion over 10 minutes. This is if the patient's stable. However, if during this administration or at any time your patient becomes hemodynamically unstable, move immediate to synchronized cardioversion. Okay, so you're looking at this rhythm and you're thinking, geez, this is VTAC. The literature supports that. If it looks like VTAC, treat for VTAC. If you're really in doubt and the patient is stable, get a 12 lead. Get a closer look at that heart. But if you think it's VTAC, it's most likely VTAC. Could it be a narrow complex tachycardia with an aberrant ventricular conduction making the QRS wide? Absolutely. Probably isn't. More likely it's VTAC. So when in doubt, treat for VTAC. Now, if your amiodarone administration was ineffective, there are other drugs you can try, but at this point you really want to get an expert consult on this patient. Again, if they become unstable, immediate synchronized cardioversion. Okay, so what's the takeaway from the tachycardia with a pulse algorithm? Here it is. All stable tachycardias get drugs or treatment for the underlying tachycardia. All unstable tachycardias with a pulse get synchronized cardioversion. That's it. And that's all tachycardias. Narrow, wide, regular, irregular, low fat, sugar-free, imported, doesn't matter. If the patient is stable and has a tachycardia, drugs or treatment. Unstable, immediate synchronized cardioversion. That's it. I'm Mark. Thanks for watching. We'll see you in the next video.